right, we are at the second part of our kind of meeting together. We have two chapters that we're going to go over. Your mini session is up, but just in case, um, I'll make sure to give you guys the link just to make sure that you guys go and check out that mini session. If you haven't had an opportunity to go look at it, okay? If we get to the group discussion, I'm not really sure if we are going to be able to, then we will. If not, we will save it. But we do have poll questions that I do want to get to. So it's kind of like, what do I want to do? So we'll probably do the poll questions for sure and then wrap everything up. The very first chapter that we're getting into is gram-positive cocci. So we have to define our key terms. We're going to look at the gram-positive. We're going to describe staphylococcal pathogens as the diseases that they cause. We have to look at the morphological characteristics, like what makes them the way they are. And then we're going to kind of think about that as we're going through the lecture. Okay, now to help us understand these classifications of bacteria, we can break them down in the ways that tie directly into what they might observe or handle, like what we're going to be doing in the operating room. Okay. We often encounter bacteria that can be classified by their shapes, by their group arrangements, and that's all going to be identified through staining and morphology, which is the study of forms and structure. And then these classifications help us to really understand the risk infection, because we want to keep things pretty sterile in our environment. Okay. So I have a lot of imagery, and I'm going to try to tie it into why it's important to us. Okay, so here's a breakdown of the focus group and the staining. We hear gram staining a lot. Now, in the laboratory, it is a technique used to just kind of grab the bacteria and categorize them, put them in different places based on the structure and the composition or how they're made with their cell walls. This method is so important for us because it helps us to identify the types of bacteria that might be present, guiding infection control and how we're going to be able to treat them. And a lot of times we are using different cleaning agents in our rooms. Now, the gram stain process itself involves dyes that are going to just highlight differences in bacterial cell walls. And so we've seen this, and now we're going to kind of like repeat this as we continue to go through with the second half of this course. With gram-positive bacteria, these bacteria, if you remember, they have thicker cell walls. They retain that purple dye, crystal violet, throughout the entire staining process. They appear dark blue or purple underneath the microscope. Your gram-negative bacteria, these have that thinner cell walls with an outer lipid layer. And during the staining process, the purple dye is going to wash away and they take up the counter stain and they appear pink or actually red. There are gram variable bacteria. Some bacteria, they're not going to have a consistent stain as purely positive or negative because they have a unique cell wall. The gram variability indicates the differences in cell wall composition and their actual lipid layers. For us, understanding gram staining and the role in selecting antibiotics is going to be important in cases where there's going to be infection risks or high or already present infection within those cases. A lot of times you're going to have antibiotic placed on your back table to present to a surgeon. Now, before they get to us, gram staining is often the first step in just identifying what bacteria we're working with and can immediately guide initial antibacterial choices. Like, what do we have? Are we going to use Ansef? Or are we going to use Keflex? It's going to be really important in those severe cases where quick treatment decisions are going to be necessary. So we're not the ones that are like, go ahead and use Ancef, but it is really good to kind of understand what's going on. So then in your mind, you're like, okay, I'm most likely going to need Ancef at some point during this surgical procedure. Again, you're not alone. You have your nursing team with you. Now, gram staining alone is not going to tell us what we have. Sometimes we get a patient on the table and we're trying to determine what it is. So we'll do a culture test where we get bacteria from the patient, it's grown in the lab, and then it kind of solidifies what we think to help us identify the exact type of organism that we're working with. There's also sensitivity tests. The chapter lets us know that that's talking about the different antibiotics that are applied to see which one inhibits bacterial growth. Do not get that mixed up with sensitive bacteria. So you have your sensitivity tests and you have sensitive bacteria. Now, if the antibiotic stops bacterial growth, it's a good candidate for a sensitive bacteria situation. But let's say you have resistant bacteria. If the bacteria continues to grow, even when you throw that antibiotic exposure, they are considered resistant, meaning that the drug is not necessarily or unlikely to be effective. Now, we also have oxygen requirements in bacteria. Bacteria can be classified by how they respond to oxygen in their environment. This is important because it often determines where in the body it's likely to be found. Aerobic bacteria, this is bacteria that requires oxygen to thrive, are commonly found on surfaces exposed to air. Now, keep in mind, we're in the operating room, and the first thing we do is we damp dust our rooms. Well, because we're trying to get rid or minimize the amount of microbial bacteria on our surfaces. So it can even be on our skin. They play a role in certain infections where oxygen is present. Anaerobic bacteria, the ones that cannot survive in oxygen and are found in environment with little or no oxygen, like abscesses, you get those big INDs, or body tissues. Anaerobic infections are common in closed wounds or areas where there's not necessarily a lot of blood flow. Now, knowing the oxygen requirements is going to help us because then we'll be able to anticipate where certain bacteria are likely to be found, and it helps with informed decisions around infection control. For example, you have aerobic bacteria, they're going to often be likely on a superficial infection. With anaerobic bacteria, you're at a greater risk in deep closed wounds. So let's say you get a patient in and they have we're going to do an irrigation and debridement. Most likely we're going to prep the patient. We're going to open up the incision, and a lot of times, a lot of stuff is going to come out. Okay. And we're going to swab. Most likely, in our mind, we're thinking this is some type of anaerobic bacteria because it was in a deep wound and it was closed, as opposed to surface area like our tables and maybe even the skin. Most likely that would be a aerobic bacteria. And most likely we're not even going to kind of culture it. But for those deeper wounds where it's warm to touch, it's red, there's pus coming out, sometimes there may be a foul smell, we're going to do some type of anaerobic culture just to confirm what we think. And that happens on the field. Okay. Now, Staphylococcus species in healthcare settings is one that we talk about a lot. We have Staphylococcus epidermidis. This is characterized by a coagulous negative, meaning it appears white in lab cultures. It commonly resides on our skin and in our nasal passages as part of our normal flora, okay? Just normal. But a leading cause of infections related to medical devices like IVs, intravenous catheters, urinary catheters, and any type of prosthetics. It can also cause bacterial endocarditis, which is inflammation of our heart. Okay. You don't want that, particularly in patients that have implanted heart disease or heart devices. HAIs frequently associated with central lines associated with bloodstream infections. We do central lines in the operating room, okay? Here's that word, biofilm, where you have that protective biofilm that's going to be on devices like catheters and shunts, making it resistant to antibiotics and immune defense or phagocytosis. You will hear that again. We have Staphylococcus aureus. This one appears yellow in lab cultures. It can grow both with and without oxygen. They thrive on skin again and nasal passages, but they have different type of toxins. Okay, they damage the host cells. They're often resistant to multiple antibiotics. A common pathogen and infecting ranges from minor skin infections to severe illnesses like boils, impetigo, um, and scald skin syndrome. Serious infections, again, there is that endocarditis again. You have osteomyelitis, which is a bone infection, toxic shock syndrome, and even bacteremia, which is infection in your blood. Okay, think about that. Now, you have SSIs, which is your surgical site infections, which we don't like. Bacteria can enter deep tissue via the wound, your surgical incisions, and even a puncture. We think about our implants. We talked about biofilm. Well, biofilm can be on implants. Infected devices often need to be removed to clear the infection effectively. I'm not sure if I shared it with this class or the other class where we had a doctor, not going to say his name because we're a very small community, and he had a history of a lot of his shunt patients getting infected. And we did everything. We changed teams. We, only had certain time they would do the case. We made sure that the room was even more clean than we normally would do it. And it came down to the actual shunt itself. It had that biofilm. And so we switched companies, and lo and behold, his patients weren't coming back with infections. So sometimes it can be kind of like figured it out that way. Okay. Now, we handle implants a lot. In cases where biofilm related infection occurs, again, you hear me saying we're going to remove it, we're going to replace it with something else. Okay. But we have to know what it could potentially be so that we sometimes, as surgical techs, you may become lead techs in your world where you have to kind of think, okay, what could this be? And you are making the informed decision. You're talking with your surgeon, you're talking with your team to kind of figure it out, because at the end of the day, we want to make sure our patients are safe. We also look at skin infections. These are caused by Staphylococcus aureus. It's important again for us when we're assessing the infection, patient's skin for infection. Yes, sometimes we're the ones looking and letting the nurse know, hey, I noticed this, because we, again, are a team. One of the most common is folliculitis, which is just inflammation of your follicles or hair follicle. It can form pustules and lead to more severe infections like furunculus and carbonucles if not treated. Okay, so just keep that in mind. Different risk factors include infected wound, a patient with diabetes, alcohol use. This is going to sound silly, but sometimes wearing tight clothing can cause that friction, and you can get it as well. And any type of general debilation. So symptoms would be pustules that form in the hair follicles. Um, Sometimes you get styes in the eyelashes. We have sometimes in the scalp, arms, legs, and children, things that we look for. Now, if the folliculitis worsens, it can become a more painful, pus-filled nodule that ruptures. And once it ruptures is when the pain is actually relieved, because there's not all that pressure building up underneath it. Severe cases cause deep abscesses where they'll come into the operating room and we are draining it, and we're actually trying to find that tunnel, okay, to get everything out. We also have impetigo. This is a superficial skin infection. Staphylococcus pyogenes is what is going to be the cause. And you can have some Staphylococcus aureus as well, but it's more from the group A. Highly contagious, begins as just a small red spot that turns into a pus filled, then you'll notice them often on the face around the nose. Okay. They're less contagious, but it can appear on the body area with large, like blister-like lesions. We have Staphylococcus scald skin syndrome, SSSS. Yes, 4 S's. This is a serious condition because now you're having skin peeling. There's redness, primarily affecting infants and young children under the age of 5. So things that you look for. We also look at erythema, which is initial redness, where the skin is like sloughing or coming off under manual friction. So like it's not going to just look at it and it's going to come off. You actually have to kind of rub it and then it'll start just sloughing off. Localized peeling, exposing raw skin underneath. All right. Patients with diabetes, they're already immune suppressive conditions. They may require closer monitoring in the operating room and preventive measures because you want to avoid the infection escalating. But we have to understand, staff, okay? Food poisoning. The chapter talks about it. Strains, it is a strain of Staphylococcus aureus producing heat-resistant enterotoxins. Symptoms, we think of food poisoning, you think of stomach cramps, right? Gastroenteritis, abdominal cramping, diarrhea, vomiting, and chills. They typically appear within 1 to 6 hours of ingestion. Often is going to occur through contaminated food, eggs, mayonnaise, dairy, potato salad, and even ham. So how do we prevent it? Well, you want to look at preventive measures, including proper hand hygiene. I think that's with everything. Wash your hands and keep your food refrigerated. Since the toxin is heat resistant, cooking is not going to be how you're going to eliminate it. Some people are like, oh, it's okay. It's been out. I'm going to go ahead and cook it. I'll be good. It doesn't work that way. Let's say it does happen, you get it, right? Or you're around. Antibiotics are going to be effective against the enterotoxin, meaning ENTER, toxin itself. So treatment is typically supportive to just manage the dehydration. Because think about what's happening, right? You're having diarrhea, sometimes it's vomiting, everything's coming out. So the patient tends to become very dehydrated. I mentioned toxic shock syndrome, another Staphylococcus aureus strain that produces the toxic syndrome associated with toxin. So it's TSST. It acts as a trigger with excessive immune responses. So you'll notice high fever, low blood pressure, rash, potential organ failure in severe cases. Toxic shock is related to tampon use, particularly superabsorbent or prolonged. You have staph infections like pneumonia, wound infections, burns, abscesses, recent childbirth, believe it or not. And any type of vaginal or nasal packing materials can also bring on toxic shock syndrome. How do we manage this? Well, you have to have urgent medical intervention because you want to address that low blood pressure. You do not want the organs to go into failure. It is not something that you can just easily flip up and reverse. Okay. Antibiotics are going to be prescribed for that bacterial infection, but they do not neutralize the toxin directly. For us as surgical techs, awareness, controlling our sterile supplies, and attention to wound care is going to help reduce the risk in patients. The chapter also talks about osteomyelitis, which is a deep infection in the bone and bone marrow, primarily caused again by Staphylococcus aureus through other pathogens can actually be involved. So patient's going to come in, they're going to have pain, they're going to have limited range of motion, and there's going to be pus in bone tissue. That is very hard to try to reverse and fix, right? Common sites are going to be your long bones, i.e., your femur, especially in children, your vertebrae and pelvis in adults. We go in there with aggressive IV antibiotic therapy, strict bed rest. Chronic cases may require long-term treatment due to it just coming back over and over. it becomes a reoccurrent infection. So for us, because I have to bring it back to us, why is this important to us? In patients with osteomyelitis, we have to be careful in positioning affected limbs. When we set up our table, sometimes we have time to break scrub and help adjust the patient. So we have to pay attention to bony promises because they're going to be fragile. Infection control is going to be important just to avoid contamination of other surgical sites. And then the chapter talks about infective endocarditis, a serious infection of the heart's inner lining, also known as your endocardium. This is going to affect native or prosthetic heart valves. Okay. We get into streptococci. We look at diseases that cause essential bacteria common in human tissues, has a wide range of infections from mild to life-threatening. We just talked about a few. We look at the familiarity with bacteria that helps us to understand the critical roles in just preventing infection. So we look at the characteristics. We look at gram-positive. We look at whether they're motile. So a lot of times they're non-motile, they're non-spore forming, and they're catalyst negative. They're often found in pairs or chains. They are classified by their colony morphology and their biochemical reactions, meaning what they do, how they react in the person, in the body. We have hemolysis. So we go back to that alpha beta. So we'll start with alpha. Okay, alpha hemolysis, where you have partial destruction of red blood cells, resulting in a greenish coloration on a blood agar. So now we have it in the lab and we're trying to figure out what's going on. Beta, complete lysis of red blood cells, meaning lysis is they're coming together. And sometimes you'll hear us say we're doing a lysis of adhesions. We do that in the operating room where we're just kind of breaking away that tissue. Once you get in the operating room, you'll know what I'm talking about. Now, these species produce toxins affecting blood clotting and white blood cells. Gamma, these are non-hemolytic species that do not cause red blood cell destruction. So nothing's happening to their red blood cell. The chapter also talks about Lancefield grouping. With Streptococcus species, they are further divided into Lancefield groups based on serological reactivity of their cell wall. The groups are labeled with letters A, B, C, D, F, and G, and they're often associated with specific infections. Group A is commonly associated with things like strep throat and invasive infections, to kind of give you an idea. We look at mild or non-invasive, including strep throat, scarlet fever, and impetigo. Severe, which are invasive, including necrotizing fasciitis. Sometimes the patients do come in with that. Those are tough cases. I'm going to be completely transparent because we're trying to get to that healthy skin. So oftentimes we're taking skin, we're taking fat, we're taking muscle just to get back to that healthy skin, get the bleeding. We also look at pneumonia, streptococcal meningitis, bacteremia. Remember that is blood. We look at toxic shock. And then we have chronic, non-supportive. These are post-streptococcal conditions like rheumatic fever, which can follow initial infections, and then you have those long-term complications. So we look at Streptococcus pneumonia. It's a gram-positive. It is an opportunist anaerobe, meaning it's going to go after, doesn't need oxygen, and it's going to do as much damage as it possibly can. Found mainly in our upper respiratory tract, and it can cause infections when immunity is already compromised. It's known for its encapsulated strains, which appear shiny. They have a little bit of mucoid on them, and there are drier stains. Okay. Now, pneumonia is a significant cause of bacterial pneumonia, especially in children and older adults. Infection leads to a bunch of fluid accumulation in the lungs due to that inflammatory response. Not bacterial toxins, but the response is trying to fix it. But in trying to fix it, it's actually doing damage. So there are two vaccines, as we know, that are available for prevention. We have otitis media, commonly causes middle ear infections in young children. In severe or chronic cases, you may be called to do a myringotomy, which is a ear procedure where we just put tubes in the ear. Okay. It's performed to really just relieve the pressure by inserting that tube in the eardrum. Sometimes they fall out, sometimes they don't. So, and I asked one of my ENTs when we were doing it, I'm like, how long do we keep these in? It just depends. We have meningitis, which is an infection of the central nervous system, particularly dangerous for actually older adults. The symptoms escalate from just like cold-like symptoms to severe neurological conditions. You have to do a cerebral spinal fluid tap to kind of figure out what's going on. Okay. We get streptococcal pharyngitis, leading bacteria causing of strep throat in adults and children. Symptoms: severe throat pain, fever, difficulty swelling, inflamed tonsil, and visible white pus patches or tonsil stones can be present as well. And these could be either or. They kind of look to me like tonsil stones, but they're definitely patches, right? Different complications. We look at scarlet fever. Some strains produce a toxin, SPE, that lead to scarlet fever, which can follow a throat or skin infection and then cause a red rash. Not to gross anybody out, but we're surgical techs. We're already claiming it, okay? So we have necrotizing fasciitis, like I told you. It's that flesh-eating disease due to the bacteria's rapid tissue destruction. And so you see where that is. In the operating room, we are cutting down so we can get to healthy flesh. So if that means that we go all the way down to muscle, we go past the muscle, it's still not, we're going to go as far as we can to get that healthy tissue back. All right. In those cases, if you're on the team, we try to keep continuity. So oftentimes when the patient comes out, we try to keep the same team because you already know what the patient needs, you already know the doctor, and that's one way we try to kind of, again, the patient is the center. But we also have things that kind of connect in different ways. There's major species, different mutants with Streptococcus. Now, many species, such as the mutants, are normally found in our mouth, believe it or not. This is why dental health is so important. Now, we look at these opportunistic pathogens, okay, under certain conditions, like a dental procedure, poor oral hygiene, or compromised immune system, they're gonna unfortunately flourish. That's crazy to say, but they're gonna go wild. We look at, let's say, tooth decay. Okay, this is a primary contributor to dental caries. Dental caries, tooth decay, that's all that is. It's involved in the formation of dental plaque. So it starts off kind of slow, but it can build. When we have infective endocarditis, it's also known as one of the leading causes of bacterial endocarditis. So think about that. You are dealing with kind of just with your mouth and it's leading and going through. And that's why I love this image because to kind of show you how important just taking care of you is. It's particularly in individuals with any type of pre-existing heart conditions or those that, let's say, have undergone invasive dental procedures. It can affect the heart valves, leading to serious implications. So for us, knowledge is power, okay? The more we know, the better we can be. Awareness, since dental procedures, oral maxillofacial, may introduce these different type of mutants into the bloodstream. We should be aware of the need for prophylactic antibiotics, which oftentimes is already signed, already ready, but just know that at some point you may be introducing this to your field. Why? Because these patients are at risk for endocarditis prior to the procedure involving the mouth from the beginning. They're already coming in and maybe they didn't even realize it. Maybe we didn't even realize it, especially for those with heart conditions or that have prosthetic heart valves. With everything, there's going to be some type of taxonomy, classification. Okay. The two most common species isolated from humans are enterococci, Bacilli. I love these words. I love butchering them. And enterococcus faecium, faecium, okay, which account for about 90% of everything going on that isolates from humans. We look at characteristics. You have gram-positive species, which are just gram-positive bacteria. We remember those anaerobes that can survive in both aerobic with oxygen and anaerobic without oxygen conditions. You have hemolysis. They are usually either alpha hemolytic or gamma hemolytic, meaning there's no hemolysis, which is going to distinguish, let us know what type of bacteria we're actually working with. Okay, so brings us to our next gram-positive Bacilli. We're moving quite along. Now we're going to determine key terms. We have to look at now gram-positive Bacilli, dealing with pathogens, looking at the diseases they cause, and the role of the pathogenic bacteria when it comes to bioterrorism. With every microbiology course, there's always a significant topic for us. Now, rod-shaped, we look at Geobacillus staphylococcus, which is a biological indicator or BI for steam sterilization. You are going to learn everything about steam sterilization because this is important to keep our patients and ourselves safe. So we look at rod-shaped spore forming. We look at gram-positive. We know it has the ability to form spores that allow it to survive in some of the most harsh environments. For us, we're looking at the sterilization process. We test an ampule or test strip. We try to look at it. We put it inside of our steam sterilizer. And you're going to do this when you get to your sites. You may do that day one if that's where they put you first. You go through the whole sterilization cycle. You take out the test strip or ampule, you're going to put it in the incubator and you're going to check to see if it's growing. Now, this is important because we want to make sure our sterilizers are working properly. If there's no growth, then it indicates that the sterilization process was effective in killing the bacterial spores and the sterilizer is working properly and you can go ahead and start putting in your first load. And that's what we call our first instruments. If there is growth, it indicates a failure somewhere in the sterilization process. And then we have to step back and take corrective measures because we can't use that sterilizer until corrective measures have been done. We don't want these instruments to not reach the correct parameters, and now patients are getting sick. Now to breaking down bacilli. These are rod shaped. They refer to large groups. They can vary in their gram staining properties. We look at saprophytes, which are the ones that feed on dead. Okay, they feed on dead and decaying organic matter. These bacteria are commonly found in our soil and, believe it or not, in the intestinal tract of animals. We've talked about aerobic and anaerobic, so we have a good idea on how that works. It's not going to change. It's just which bacteria we're dealing with. Are we dealing with cocci? Or are we dealing with bacilli? Okay. Let's get into some of these bacteria. Now, bacillus is historically significant as the first, you may see this again, bacterial species proven to cause disease in humans. This discovery, made by Robert Koch in 1877, was pivotal in the development of the germ theory of disease. He demonstrated that B. anthracis could form spores, which, when injected into animals, caused none other than anthrax. This experiment solidified the link between specific pathogens and actual diseases. Getting into anthrax. This is the most common, cutaneous anthrax is the most common form of the disease. What happens is spores enter the body through breaks in the skin, often during handling infected animals or their products. It could be their hide, their wool, or even their hair. The crazy part is you have some painless bumps appear 1 to 7 days after you've been exposed. The bump turns into an ulcer with a necrotic, meaning dead tissue in the center. The infection most commonly affects the head, the neck, the forearms, and the hands, because you got to think, you're touching it with your hands. A lot of times we touch our head, we touch our neck, and the outcome is crazy. So you have cutaneous anthrax. It's rarely fatal, believe it or not, with timely antibiotic treatment. The infection is treatable with those antibiotics. However, without treatment, it can lead to serious complications. So that's cutaneous anthrax. But what happens if you inhale it? Typically contracted by workers in industrial, like wool processing, which makes sense because think about where it's coming from, slaughterhouses. Inhalation anthrax is caused by breathing in the spores from contaminated animal products. Symptoms develop within 7 days, but can appear up to 2 months after exposure. The spores then will multiply in thoracic lymph nodes and then spread throughout the body. Inhalation anthrax is the most lethal form of the disease with a 45% mortality rate, even with early intervention. I'm going to repeat that. Inhalation anthrax is the most lethal form of the disease with a 45% mortality rate, even with early intervention. Now, without proper treatment, the survival rate drops 10 to 15%. Respiratory failure and shock are common causes of death. There's also gastrointestinal anthrax, as well as injection anthrax. And we diagnose it underneath the microscope. Okay. Cultures, samples are taken from the skin lesion, maybe from blood, maybe from respiratory secretions, or even other bodily fluids. We measure the antibodies in the blood, and then we also confirm the infection is present. Again, trying to get them that antibiotics, the most effective treatment if given early, especially before it starts to spread throughout the lymphatic system, is antibiotics. Common antibiotics include ciprofloxacin and doxycycline. Due to the spore formation ability, anthraces exposed individuals may need 60 days of antibiotic treatment just to prevent delayed activation of spores. Keep in mind that you want to get to it early. So early treatment is always better with everything. We get into Bacillus cereus. This is a gram-positive, facultative, anaerobic, motile, spore-forming bacterium that is capable of breaking down red blood cells. It's commonly found in soil and can be associated with a variety of infections, but again, most notably, gastroenteritis and eye infections. Now, with gastroenteritis, we look at emetic toxins, one of the main cause of food poisoning. The toxin causes vomiting and is typically associated with fried rice, which sucks because I like fried rice, or other starchy foods that have been improperly stored and then reheated. The incubation period of the symptoms is relatively short, 1 to 5 hours after you've ingested it. We have endophilitis. It's caused by external trauma to the eye, such as penetrating injury or foreign body that introduces the bacteria into the eye. So when you get a patient that has an eye injury, you're going to notice that, let's say there was a pencil poked through the eye. We're not pulling that out. They're going to come in with it still in the eye, and they're going to have like a cup or something protecting it and wrapped. So just keep that in mind. All right. We get into Listeria. This is a genus of bacteria with 6 species. Okay, 2 of which, Listeria monocytogenes and Listeria evolinovi. These are known to cause disease in us as humans. The bacteria are found in soil around the world and are capable of causing a range of infections, including food poisoning, meningitis, and bacteremia. So you're noticing getting a lot of the same symptoms. So that's why it's super important to determine exactly what it is the patient has been infected with. Listeria bacteria stain purple when subjected to a gram stain. They're non-spore forming, unlike some other bacteria. Now, the enzyme catalyst, what it does is it comes in and it breaks down the hydrogen peroxide and is used in laboratory testing to kind of determine what type of bacteria are we dealing with. We have lactobacillus. This is a gram-positive, rod-shaped, non-spore forming bacteria that are known for their ability to produce lactic acid. Now, these bacteria are considered either facultative anaerobes or strictly anaerobes, meaning they can survive in both oxygen-rich and oxygen-poor environments. They play a huge role in food production. Lactic acid production is where we have that formation or the fermentation process of lactic acid, which we know is important in the food industry. And it's crazy because despite the fact that it can spoil food if not controlled, it's it's responsible for the production of foods like what you see in front of you, pickles from cucumbers, sauerkraut from cabbage, and yogurt from milk. The lactic acid produced helps preserve the food and contribute to their unique flavor profiles. But in humans, it is a lactobacillus species. There are commensals, meaning they naturally exist in various parts of the body without causing any harm. Now, these bacteria are part of the normal microbiome and can be found in the vagina, oral cavity, and even the intestinal tract. Now, in pregnant women, it plays a big role in the development of the newborn microbiome. As the baby passes through the vaginal canal, it becomes covered with all of this lactobacilli, establishing the first microbial population for the actual infant. We get into the genus Colostrum, which compromises up to 100 species of anaerobic, gram-positive, spore-forming bacilli. These bacteria are mainly strictly anaerobic. Again, they thrive in the absence of oxygen. Which allows them to survive in different ways, but not grow efficiently under different conditions. So they're commonly found in water, soil, sewage. They are part of that indigenous flora in the gastrointestinal tracts of both animals as well as humans. So you see a couple things up there: gas gangrene, botulism, more specifically infant botulism, tetanus, and C. diff. We get into breaking these down with gas gangrene. It is life-threatening. The infection often results from some type of trauma, surgical wound, or poor blood circulation. It is characterized by tissue necrosis, the production of gas within affected tissues leading to swelling, severe pain, and potential fatal systematic effects if it's not treated. Botulism. It is a neurological disease caused by the botulinum toxin. It breaks nerve function, leading to muscle paralysis. The disease can occur through ingestion of contaminated food. So that would be like a foodborne botulism, wound infection, or in infants where you see infant botulism. We have tetanus. Tetanus is caused by the tetanospasm toxin, which leads to muscle spasms and rigidity. So they become stiff. It's often associated with puncture wounds, particularly from rusty nails or other contaminated objects. Tetanus can lead to severe complications, including respiratory failure due to paralysis of the respiratory muscles. And then C. diff. This bacterium causes colitis or inflammation of the colon, often after antibiotic treatment disrupts that normal gut flora. So they had something going on, they didn't feel well, they took antibiotics to treat it, and now their normal flora has been disrupted. C. diff unfortunately produces toxins that cause severe diarrhea, abdominal pain, and in severe cases can lead to colitis or toxic megacolon. It's a major cause of healthcare-associated gastrointestinal infections. Now, this species, they're very powerful pathogens due to their ability to form endospores, produce toxins, and grow rapidly in anaerobic environments. They are responsible for several significant diseases, including the ones that you see, gas gangrene, botulism, tetanus, and colitis. That means we have to understand these because they're going to diagnose and they're going to treat these diseases that they cause. The last thing we're talking about is kind of breaking C. diff a little bit more. Okay. What is Clostriditis difficile? C. difficile. This is a type of bacteria that naturally lives again in the human gut, but can become harmful in certain situations, especially, unfortunately, in hospitals and healthcare. But why is this important? It's a major cause of HAIs, leading to, again, severe diarrhea and can be dangerous in patients that already have a weakened immune system, particularly those who have had many antibiotics. Because remember, they take that antibiotics to treat whatever they were treating, and now their normal flora in their gut has been compromised. It's like a necessary evil if you kind of think about it that way because they're fixing something, but now they have been more susceptible to something else. C. difficile can survive in heat and stomach acids, making it difficult to eliminate. Now, once it gets into the gut, it starts to release those toxins that damage the colon, causing long-lasting diarrhea and inflammation. The bacteria can overgrow, especially after long-term antibiotics. That again disrupts the natural balance of gut bacteria and it allows the disease to thrive, the bacteria to thrive. Now, as an ST, understanding how it grows and spreads helps us to be more proactive in preventing infections, especially in those patients that have had surgery and may already be on antibiotics. Knowing which patients are at higher risk can help us just take a little extra precaution to prevent infection, particularly when we are working areas like the gastrointestinal tract. Keep in mind that in severe cases, the infection can damage the colon so badly that parts may need to be removed surgically. That's why it's important to us when you're getting in and you see that you are doing a bowel resection, just know that most likely there's something going on with their gastrointestinal tract. Recognizing the signs of C. difficile infection early, particularly in postoperative patients, is going to be important to prevent severe complications like having to come to us for those bowel surgeries or further infection. What questions do you have for me? I know that was a lot of information, but don't worry, I do have a couple poll questions. So for those of you who are watching, you're going to receive the same questions that they are getting this evening. For those of you that are here, the questions that we have, you have 5 true and false and 5 multiple choice, but I chose the 2 most highly questions in the multiple choice that are usually chosen. These are all from the concepts from just this chapter, okay? Or these 2 chapters, I should say, to kind of really just help reinforce the information that we covered, okay? So I want you to take your time. I'm going to give you guys a couple minutes and then we'll come back. All right. And then wrap everything up. All right. And we are back. Again, like I mentioned, for those of you who are watching the archive, you will be able to see the same questions that everyone has been presented tonight in the live session. For the discussion forum, what types of bacteria typically cause conditions that require the surgical intervention by an ear, nose, and throat surgeon? Which types of microbes can cause gas gangrene? And how do antibacterial infections manifest their signs and symptoms? Today we covered a lot of information on chapters 12, gram-positive, and chapter 13, gram-positive cocci and bacilli. Your mini session is up. Make sure you guys go and look at it. And if you have any questions, y'all, please let me know so that I can kind of break it down. Anything that is a little bit harder to kind of understand. I try to do my best, but it's a little bit harder when we have these mini chapters. So please let me know. As we conclude, I do want to encourage you guys to stay engaged. We are past the halfway mark and it's going to get faster. Um, I was able to complete your professionalism score. So if you see any discrepancies, again, I'm human. So if I've made a mistake, just let me know so that I can kind of fix it ASAP for you. With that, I am wishing you guys to have a wonderful rest of your evening, a wonderful rest of your week. Be safe this weekend, and I look forward to seeing everyone in next week's live session. Good night, everyone. So I will make sure.